All right. Hi, everyone. My name is Jeff Frankel. I'm the managing editor of GEMS. This podcast is brought to you by Firehouse Subs and the Firehouse Sub Public Safety Foundation. Quote, enjoy more subs, save more lives. Find out more about restaurant ownership at www.firehousesubfranchising.com. All right. With me is GEMS columnist Jonathan Feit and Dr. Eric Yazel.
You're good. Yeah, it's Hazel with a Y.
Hazel with a Y.
You're good, man.
I asked him off camera, what's your name? He told me, and I messed it up
You're all good.
off the bat. So apologies, doctor.
All good. No worries at all.
So, Jonathan, I hear we're here to talk about seismology, earthquakes.
So we're going to continue the conversation that we were just having off screen. So everybody here feels like they're in on the party. What we were talking about initially, we're going to go over a ton of different things today. And I'm super excited, by the way, Eric. Thank you for joining us.
Absolutely.
It's a pleasure.
Excited to be here.
Jeff, it's nice to see you.
Hey,
Not on Zoom.
Yes.
We're so used to doing this, the Sacred Cows and Data Cubes podcast for GEMS, which I love doing. In case you aren't aware, the title came from a title of a book that I was introduced to that is called Sacred Cow Makes the Best Hamburger. So this is what we're going. I don't know if you knew that. The origin of the story.
You're fired. This is terrible.
I didn't write the book. I just mashed them together. So it's a data-driven discussion about all the things that folks are thinking but don't say on record. But, me being the Tourettic that I am, I just can't help myself. True story. That's not a but-bum, but, it just comes out. So to bring everybody into the conversation we were just having, we were talking about the unusual experience of New Jersey shaking.
Where I live, by the way.
Right.
Born and raised.
So it wasn't random. And I just wanted to start out this complete with it. We're at a fire conference. A lot of folks here specialize in medicine and rescue and extrication and pulling rocks off of people after the building has collapsed on them. And I thought folks might find it an interesting fun fact to start off with. It seems like a complete non sequitur, but it's actually somewhat relevant that I have found a correlation, and I don't know if anyone ever talks about this, but in the places that have earthquakes a lot and other weather phenomena, that their housing are related to where they live. Ever think about that?
No.
Right. So if you're this is why it was actually really scary for those of us in California. I'm from California. For those of us in California to hear about an earthquake in the Northeast is that our houses mostly are made of wood, right? Because wood will bend when it shakes. But if you have bricks, like places like in New England, and they shake. So the shake, did you know that the shaking will actually pulverize the bricks?
Makes sense.
So
Yeah.
they collapse.
Yeah.
Right, when you look at the Midwest, do we count as Midwest
Yeah.
in Indiana?
Yeah.
I'll say so.
Yeah.
Kind of the edges of the Midwest?
We're getting to,
I just find it funny. Like the Midwest seems to be everything that's, basically east of the Rockies until you get to, I can't even say Eastern time zone because we're in the Eastern time zone.
True.
Right? So you're like Midwest, but not on the Central time zone.
I think you're right in the heart of the Midwest. I think you're good.
Fair enough.
Yeah.
And then there's Kentucky. Do you have two time zones in Kentucky?
We do.
Right.
Yep.
So that's just confusing to the rest of us who, between you guys and Arizona, we're just
Yep.
SOL.
Yep.
So you have storms, right? And so the construction of your homes are designed to withstand or to not withstand, right? Major storms and be easier to put back together.
It's fair.
What do you
You're kind of in tornado territory here. And
Right.
You see more basements in this area than you will
Right.
anywhere else because tornadoes are good. I mean, it's good to hide out in a basement.
Whereas in California, we can't have basements because they will pancake.
Oh, wow. I know that, to be honest.
No basement, very few basements in California. So
Interesting.
yeah, because the house will collapse on stuff. But fun fact, the biggest towers in Los Angeles, for example, basically all over the state, the newer towers that are like the last 60 years, do you know they're built on wheels?
Really?
So they actually roll, they swivel. So these ginormous ball bearings that are underneath. See, this is why I wanted to start with this. Save the cows, data cubes. We're changing minds and talking all kinds of things. Yeah, so they're based on they have these giant ball bearings, and so the skyscrapers will swing in the earthquake because otherwise they'll snap. Right? If you basically are standing upright and you're basically shaking, oscillating, right? So the top floors would feel like crazy, and then the whole building would snap and fall over. And so this way they
Might have to change my pants if I was in one of those moving that much, though.
Well, a little bit.
Yeah.
I mean, it's I would say it's more like now I have that image in my head. Thanks for that.
You're welcome.
My thought was actually more like the hula
Okay.
skirt in the truck, right?
Yeah.
The classic sort of bobblehead. That
Mhm.
kinda, but it never falls over. But now I'm going to picture you.
Hey, you put me on the top of one of those that's moving like that. Yeah, I think I don't get nervous too much, but that would definitely do the trick.
Well, that's going to be our lead-in. So, Dr. Eric Hazel.
Nope.
Yazel. Yazel with an H. Yazel with an H, right? I love it.
Yeah.
Do we have a 3-second break on this one? Can we go back?
No, we're live.
This is like, I know this isn't like the TV news where you can do it.
Nope.
Say, never mind. Start over.
We're live.
So Dr. Eric Yazel, who, by the way, has a fan club. If for those of you who didn't know, I've met several of those members this week, by the way, who are at another event completely. They unfortunately can't be back in Indianapolis yet because they are, where were we? I think we were in California yesterday, if I remember where I was. And they're at a conference over there, which we're going to get to talk about. But they absolutely adore and appreciate you. There's a lot of people from a lot of different parts of the profession, the industry. So why don't you take a couple minutes, tell us a little bit about yourself before the earthquake experience. Because now we know what you're like in the earthquake experience, and that visual will be lost on no one.
There you go. I'm a born and bred Hoosier, Indiana resident. Grew up in northern Indiana, then lived on the east side of Indianapolis here. Now I live down in southern Indiana. Actually got into EMS way back when. I did a rotation down at Grady Hospital in Atlanta, and part of it was riding along with EMS. And I was like, these are my people. And so when I did my emergency medicine residency and then got out, immediately started with medical direction of some local services. Really been with every permutation of EMS, private, public, rural, urban. If it's any style. Oh yeah, absolutely. Fire were my first ones.
Okay.
Absolutely.
First love.
And actually, the only one that I still held on to in my current position.
Okay.
Couldn't let
Makes
go of my
sense.
fire-based services.
And by the way, I didn't lead him on any of this, but I have on my notes here EMS, fire, rural, urban. We're going to be talking about a lot today.
Good.
And some CPMIH, because I know you care about that. So we're going to come to that.
Well, and that's where we're one of the few health departments in the state of Indiana that has EMS oversight. So I got into public health, and that's kind of a natural transition into mobile integrated health. Started to get involved at the state level through that, and kind of led me to where I am today. So.
Okay, and physically where you are today is actually closer to Louisville.
Yeah, I live about 30 minutes northwest of Louisville. I'm in a very, very rural area. Do about half my time at a trauma center there at University of Louisville, then the other half at Norton Clark Hospital in Jeffersonville.
Awesome.
Yeah.
And before we get into any of the serious stuff, for all those of us who are not from here, but I'm sorry. What's a Hoosier? I've actually wondered that for a lot. I had to ask about what a Buckeye was too, by the way, in Ohio. And I know there's a football team and a culture, but I don't know what an actual. It's also a movie, right?
Yeah.
Gene Hackman.
Right.
Yeah.
Right.
So I have some context.
Right.
On what is a Hoosier?
So it's funny you say that. My daughter asked me that actually as a Indiana resident what that was just like 2 days ago. There's a lot of different theories.
I feel better now.
Right? I think it comes from, and you'll hear the southern accent from me a little bit too, is in the hills down in southern Indiana, when they'd hear somebody coming, they'd say, "Who's here?"
Okay.
And so they started calling them "Who's Here's," and it just morphed into Hoosiers over time.
Interesting.
Is the most viable theory. There's other ones I've heard of a bar fight where somebody's like, "Whose ear is this?" And some things like that. So not entirely sure, but that was the most credible explanation was the greeting style. So
I like that.
yeah.
So this does seem to be a regional thing. Are you familiar with a Yinzer?
Yeah.
Yeah, I am.
So right,
Pittsburgh.
Pittsburgh.
Yep.
Do you know the story of where those came from? Because that seems to be completely relevant.
No.
So apparently the story of the Yinzer is it's someone who may have been exiting an establishment featuring adult beverages.
Okay.
And they referred to use guys, but instead they said yins guys. And so now a Yinzer derives from the contraction, strangely, of you guys somehow ended up with an I and a Z. And now Yinzers are people from Pittsburgh.
Nice.
So
Interesting.
How about Jonathan, California? What's that? And it's so broad and so big, and
Yeah.
a lot of people there. Is there a certain name for Californians? Yeah, it's kind of boring.
what's actually really horrible is my first instinct was to say, like, people from like California, like we just like talk about whatever, like Valley Girls,
Yeah,
from
right,
California. We've got all kinds of. There's so much I want to say to that I'm not going to say with a microphone in front of my mouth. So, Californians,
Yeah.
Angelinos.
Yeah.
So it's you, right? You're from Los Angeles?
I'm from Los Angeles. I will say, I don't mind saying this. My wife is Mexican. She hates the Latin X
Yeah.
thing. She says you're Latino or Latina, but the Latin X thing doesn't make any sense. And that seems to have come out of California. And I find that it's actually, there's now, I mean, not to get into those sorts of politics right here, but it does seem to be reverting back because a lot of people kind of leaving it aside because the folks who are from the Latina culture do not use Latinx in general to describe themselves. It tends to be folks describing that community. So it seems like these local names actually do matter to folks who are from them. So now I'm wondering, we got covered Pittsburgh, we covered Indy. I'm kind of wondering what folks from Cleveland and Columbus call themselves kind of on the way here on the freeway.
That's a good question.
Good answer, I guess.
So speaking of culture, so I'm very interested, again, given you cover a lot of different lines, right? When you look at, for example, Kentucky and medicine there versus medicine here, what do you think? What do you see? I attended, by the way, some context to the question. I attended a Society of Trauma Nurses conference there a couple of years ago. And there's actually a lot that came out of that for me, including for the first time hearing trauma nurses say in front of a room, basically devoid of anyone from EMS, fire, or mobile medicine in general, how can we do our jobs right if we don't know what's coming in the door? And I thought that was such a stark contrast to the perception that mobile medical professionals have of themselves, which is that the folks on the hospital side or the folks in the nursing community, et cetera, don't care what we have to say. And here I was hearing them, and I don't know if that's a Kentucky thing, it's a Louisville thing. There's some really interesting programs that have come out of Kentucky. What do you think? And how much does culture play into that?
That's a great question. Number one, the population distributions are much different, right? In Kentucky, you have Louisville, Lexington, and then some of the Cincinnati suburbs, but otherwise it immediately goes to a very rural phenomenon. And then you have your trauma center utilizations, and there's a kind of a disconnect, I think. Indiana is a little more, it's kind of a spokes on a wheel, right? Everything is concentrated inside 465 in Indianapolis, and it kind of fans out to the periphery of the state where, again, you have some bigger centers. So just the distribution and the connectivity is different there, and that creates a little different, phenomenon and a cultural difference and things too. So
okay,
yeah.
How much of it has to do with the folks who are choosing, for example, to live in one place or another? You think is that a bottom up phenomenon where, again, folks who are choosing to urbanize versus stay in a more rural environment? Now, I'm leading to some of the innovations that have come out of Indianapolis that I'm actually really fascinated by. So tell me what you think about whether that is sort of, again, just the way that, again, when I think about California, our whole state is younger than this area. This town is older than my whole state. But how much of that is people reflecting sort of where they live, where they want to live, where they choose to get care, versus, for example, a community that is urbanizing? Clearly, Indianapolis is beautiful. Indiana has amazing corporations. Kentucky does too.
It's interesting. I always use my home county, actually, as kind of a microcosm of all this. Clark County, Indiana, sits right on the Ohio River. Yeah, it's not a huge county. We have 125,000 people, but I always say 124,000 of them are smooshed up against the river as an urban suburb of Louisville, and then it gets very rural from there out. In the same county, you have 20-minute drive in some places to get to a gas station. Wow. And from an EMS side of things, that presents a very interesting cover. Down in the urban area where, 90+% of your runs come out of, it's a whole different dynamic. And, you're trying to push the issue and care and things like that and help the services reach their potential. Out in the farther reaches of the county, you're just trying to get somebody out there in a timely manner and figure out creative ways to use your workforce that's dispersed out in the county. We've done some things called community aid stations where interspersed throughout our county, we have Narcan, a stop the bleed kit, and an AED. And they're for public access so that, say you have a trauma nurse, like you mentioned, or a paramedic or, firefighter anywhere out in the reaches of the county, when it's a 20-minute response time, but you may have somebody 2 minutes away that would help if they only had the tools and the knowledge that somebody needed help right down the road. And so those are some creative ways we've tried to bridge the gap in our rural areas, simultaneously kind of, raising the bar in our urban areas too.
Well, it sounds amazing. Talk to me about the knowledge side of that. I saw a statistic, I want to say in the last 48 hours. I don't remember which event it was at. I've been at several events in the last 2 weeks, all of which are relevant here. Actually, incidentally, one was about roadway safety, one was around palliative care, one was around maternal and child health, and now we're at fire and EMS and innovation and so on. So they actually, sort of capstone in a really interesting way. But there was a scary statistic actually that came out around the non-utilization of AEDs that I saw. And for me as a technologist, again, thinking about this idea of sacred cows and the data that theoretically could help to accomplish things, my mind immediately went to Pulse Point. You know the Pulse Point, right?
Yeah.
Incidentally, created in the area that I live in. So San Ramon Valley Fire District, actually in California, created the Pulse Point app. Fun fact.
That's a fact.
So and it has taken off, and yet, do people know that it's there? Right? Now, I have, as we were, we talk about, Jeff and I were nerding out on comics and things earlier. Was a Nintendo child? Nintendo?
I was Atari. I was even a little older. Yeah. Yeah.
PlayStation for me.
Yeah.
So,
SNES.
do you remember this story, or that people would blow in the cartridges when they wouldn't work? Or hearing about that? So I've actually been fascinated about this intellectually for at least 2 decades, because somehow there were kids all over the United States
That knew how to do it.
Yeah.
prior to social media.
Yeah.
Right. Right. We talked about this already.
No, I know it's theory. I heard about this too.
Isn't it fascinating?
It is. How to know?
So the diffusion of knowledge,
Yeah.
I think, is a fascinating question.
Yeah,
It is.
And now in EMS, I know I sort of circle the drain with my topics here, but I promise I'm going somewhere. These are fascinating.
Let's
The diffusion. Like I said, that clock's got plenty of time on it, my man. But the diffusion of knowledge is a fascinating topic, I think, intellectually, that we don't in general, I think we take for granted, right? There's so many ways of connecting now. They weren't always there. But now there's this really interesting trend, for example, around utilization of 911. Right? And the controversies, some of which I'll be presenting at later this week if you happen to be here, around ways to pay for things like community prayer medicine. Right? But so much of the conversation has gone from teach people how to call 911, when to call 911. Now let's maybe unteach them to call 911, right? Yeah. And now we're teaching them to call 988.
Yeah.
And there's this conversation. It sort of gets dark in a hurry. But if you're calling 911 and someone needs to connect you to 988, because that's the more appropriate way to get care for what your needs are. But it turns out there isn't a way to connect in most jurisdictions, 911 to 988. We were just talking about that at this maternal and child health conversation less than 48 hours ago, right, where California and other jurisdictions were talking about the very real tragedy of postpartum depression, right? And in fact, to make it even darker, it was specifically a conversation. In fact, it was from the California Department of Public Health, if my memory serves. Good, not enough coffee today yet, but let's assume I'm right on this. But they were talking about how certain demographic groups, certain communities, have a dramatically higher rate of suicide pre, even during, and post birth. The during one jolted me particularly. Like, I mean, the idea that someone is actually killing themselves while having a child.
Yeah, it's sad.
I can't. My mind actually has trouble reconciling that. If you've experienced that, I'd actually would love to have you elaborate on sort of what that is, because it seems like a tragedy that we need to engage. That again doesn't get talked about. It's so taboo, right?
Yeah,
We don't talk about it. But to me, that became a rubber hits the road. Serious as a heart attack kind of moment, where if someone calls 911 and goes through the story of the stress they were experiencing for a telecommunicator. In fact, we're in telecommunicators week, right?
Absolutely.
Happy Telecommunicators Week to all the folks on the PSAP side, all the dispatchers out there. Thank you for your service.
Yeah, thank you. Hard workers.
Hard workers. And I find myself trying to internalize the trauma, which we don't talk about enough in any community, let alone the folks behind the phone. What it must be like to have to tell somebody, I'm sorry, I'm going to have you hang up and call another number and tell your story again, right? So that trauma, right, is something that certainly I don't think we're talking enough about. But when how do you approach those types of efforts? Again, I started talking about Pulse Point, right? Sure. Talking about technology and this AEDs, right? We need to diffuse awareness. We want to direct people down the path of care. They may not know what's available.
Mhm.
Once we tell them what's available, they use it. Now we want them to use it less, or we want to use something different. I find it's hard enough to get people to use a new EPCR system. Now we want to tell people that they have to call a different number that they've been told since they were 2 years old. Call this in case of emergency. How do we diffuse knowledge into especially again, you've got rural, you've got urban. How are you teaching people how to use these kits and so on that are available? Tell me all the things.
No, that's a great question, and it's
a long
interesting.
question.
When you mentioned Pulse Point, everybody that down in my home area is probably like, oh, here we go. You know how they make fun of people for talking about CrossFit too much? I'm like that with Pulse Point. We're a huge Pulse Point community, and what happened was we actually got some mail from Pulse Point for Clark County, Nevada, on accident in Clark County, Indiana, and I'm like, what's this Pulse Point thing? And at the same time, one of the local fire chiefs was talking about how there was a cardiac arrest across the street from him. A guy he knew had no idea until he saw the EMS unit pulling his driveway. And he's like, man, I would have been there in no time. I just didn't know about it. And we started talking about it. And we're like, this is the pathway to get there. Yeah. And then we just kept building it. And one thing we did that's a little different is as we started QAing our Pulse Point notifications, we started noticing that, it goes out for anything unconscious, unresponsive. But we got hit hard by the opioid epidemic, like the whole United States did, but especially hard in our area. And a lot of our overdoses.
By the way, on the Kentucky side, the
Indiana side.
Okay.
Both, but this is more specific to the Indiana side.
Okay.
And so we started QAing our Pulse Point notifications, and we found out a lot of our overdoses were going out like that. And so what we started doing is going out in the community and doing all sorts of creative Narcan training, drive-through Narcan training. We have a Narcan. We do leave behind with our mobile integrated health programs.
How's that going?
It's good. Yeah. We have a vending machine outside our ER too, so anybody can get access. And so as we look, our overdoses were down 40% after that combined with a lot of other programs and efforts, right. But we're able to do that. But it takes a constant amount of effort out in the community. We noticed during the pandemic, when obviously we were sidetracked with other things, a lot of our community education, our Pulse Point interactions, and our community aid station things that engagement started to decrease. And it just takes a constant intentional effort to get out there, especially in the rural areas where, outreach can be a little more challenging. You don't get the high yield events with several thousand people, so.
Well, and so in your role or in your view, when you convince people that these programs, or are you the one convincing people? Let me ask you that. Are you the one who's sort of out there evangelizing for the need for this?
I do think one of my biggest priorities in my state position is boots on the ground. I came in, I said I'm going to visit all 92 counties as soon as I can. I'm getting close. There's still a few outliers, but I want to be somebody who's visible, that when they picture somebody who's at the state level advocating for them, whether it be programs, legislature, things like that, it's somebody they can put a face with it that they know I'm representing their true interests and not somebody just sitting in an office that they've never met. So
I love that. That's great because, I'm not going to name names, but in the past, that's not just here, anywhere. It's, people on the desk making decisions, and I like they're being upfront. And here you are right now at FDIC, and that's great for us, good for you, great for the state of Indiana. So
it's good, and then it's great because I learn something everywhere I go. It's just great knowledge and knowledge translation. I can tell them what's going on at the state level, but I learned something from them. And when there's an issue now, I can picture them. I know what their station looks like. I know their local setup. So I'm already one step ahead when there is an issue at the, local level, whether that be rural, urban, doesn't matter. And it's really cool. A lot of places I've been, they're like, you're literally one of the first state officials to ever set foot in our place. And that means a lot to me. And I know it means a lot to them.
It does.
Well, so I have two thoughts that are swimming through my head. First is I have the pleasure of working with some folks in Texas. They have 254 counties.
I
find myself thinking, I wonder what the folks over there would say. I'm going to go to all 254
right.
counties.
Say 92 is hard enough. So I can't
well, not just that. Imagine if you did one per day. You've got almost an entire year just on the visit.
And I would guess they probably have some monstrous counties geographically.
And they've got some very small ones too.
So,
I'm fascinated by even what the conversation was with the team as you were describing. Let's get into that in a second. But you also practice medicine. You were telling me earlier you worked an overnight last night.
Yeah, correct.
So this is the takeaway for the audience. We're going to learn something particular right now. When do you sleep?
Well, that's iffy.
and what are your solutions? Yeah,
that's a great question.
Secret,
Number one, and this is going to sound cheesy, but I mean, I'm out in the state trying to teach and tell people things to do. And if I can't clinically do it myself, intubate, do procedures, then, what am I really doing out there? And so, I work in the private world to keep my skills up, and I work in the academic world so I can teach, stay up to date on current trends and research and things like that. So those are just things that I'm not willing to sacrifice. So yeah, I do end up sacrificing some sleep at times.
Yeah, no, legit. When do you find the time in the day? I mean, I feel tired just getting on a plane and coming here to have this conversation with you. You worked in a clinical environment yesterday. You managed to find your way here, and I'm assuming you're going to be doing something else later. Hopefully, going home, seeing family.
Well, so
football, by the way, let's talk about
You've heard my Colts thing?
I read the story. It was great.
Yeah,
I tried to throw it up a little.
I don't know if you saw the actual news clip, but I was wearing a onesie on the local station.
I missed that. But you better believe it's going with the other
right now.
You better believe we're fine.
My wife's like, I'm embarrassed enough, and then you went on our local TV wearing a onesie, which is So I'm usually in the doghouse anyway, but that doubled down on that. So yeah.
I mean, I don't know that that's better or worse than there may or may not be a clip of me out there looking at a camera going, as I was staring at the crowd. But we've all got our stories.
But with some of this, I actually am more 8 to 5. My day starts at 7 and it stops about 5, and I get blasted that whole time. But then I am off at 5, so I don't miss any of my kids' sports events, things like that. And then I mix in. I only do 2 or 3 shifts at each location. Enough to keep my skills up, but it's doable.
So what period of time, for example, did it take you to visit all 93 counties?
So I've still got a few.
Or most of them.
I still say it'll be 2 years in June in my position, and I've hit almost all of them, and some of them I've been several times and things. So yeah.
Well, from the research I did about you, one of the I won't tell you all the things that I know because that'll just be scary and weird. But you look great. So creepy. He's never having me back. He's like, oh man. But I know that responder wellness is an important part for you. So again, I think we're at an event where this is an important topic, and we all know people who we've lost. I recently had the I can't say pleasure. It sucked. But I wrote an obituary for a friend of ours named Mike Touchstone, who passed.
That was nice, by the way.
Thank
nice
you.
Job on that, and a legend lost.
He earned it. I mean, absolutely. It's an unfortunate, but I don't think there's enough attention paid. So again, there's a lot. I know we're covering a lot, but some of these topics intersect, and where we are at FDIC, but also in the GEMS Innovation Conference was happening today, and I was in there for a few minutes listening to people talk about, for example, how they're making sure that the people that they're with are okay, right? I mean, even the act of community paramedicine, as distinct from extrication from a vehicle, not the same. Dealing with kids as opposed to dealing with elderly, not the same. So I think we need to talk about, and one thing as a clinician, I would love to get your thoughts in that regard, if you don't mind, but also practically speaking, I don't think there's enough science that talks about the prevalence in our profession of cancer, of ALS, certainly of suicidal ideation and the psychological toll that it takes. But even barring that, the physical, somatic, physiological damage that's being done, and the rates are too high, right? I'm not just talking about from exposure to things like that. I'm talking about, has anybody ever looked, to your knowledge, at, again, things like ALS that we don't know those are environmentally triggered. We know cancers are, right? But how is it that we have so many people around us? Is it do we think that folks sort of are drawn, for example, so many people that have ALS have it in their family, right? There's a genetic component to that. I find myself curious whether folks who had disability like that in their family are therefore drawn into service professions, and therefore find themselves then getting exposed to things. What do you think is the state of the science, before we talk about how you educate folks about their own wellness and get the word out on that regard as well?
That's an amazing question, and it hits close to home, actually.
Take as long as you need.
One of my first exposures to the fire service was a family friend. He used to take his kids to school every day, and he was a fire chief of one of the services here locally. And he ended up with ALS, and I've seen actually a guy who was a father figure to me down in Jeffersonville passed away of premature colon cancer. And so,
Sorry for your
and you
loss.
see that, you see these things, and with like, and I know you can there's dangers in these one-offs, and just assuming prevalence from things that hit personally close to home.
Those rates
But
or something.
But when you sit down and look at the rates, it's terrifying. And then as we learn more and more about the interplay between physical health and mental health as well, combined with some of the occupational exposures, that chronic baseline of stress, I always say we do everything from a mental health side of things completely ass backwards in EMS. We say, here, we're going to put you in a profession where you're going to see things that no human was meant to see. We're going to let
All the
you,
time.
day in, day out. And then, 6 months, a year, 10 years, whatever it is, when you start to struggle with processing it, we tell you on the back end what you should have done different all along. And that's a poor way to handle that. And so we've really looked here locally or not locally, but statewide, as far as what are the best practices? What's the evidence say? And we've really tried, we have a volunteer department down my way that we did a very comprehensive cancer screening, genetic testing side of things.
Okay.
And so we're starting to get that out in our services. We're looking at mental health support and kind of best practices, from beginning to end, pre-employment stuff, peer support, critical incident stress management, virtual options, just a whole kind of laundry list of things, because it's not just one answer of this is mental health and this is how we're going to do it. But, every service everywhere, whether that be urban, rural, needs to have those options. And we need to understand the evidence behind what we're trying to do for best practices.
So here's a fun fact that's not so fun. And I'm going to come back to the ALS stuff in a minute too. But did you know that there is no electronic health record system that tracks responders from recruitment to retirement? Doesn't exist.
I believe that.
I'm in the tech world,
Yeah.
right? So
Yeah.
our sort of the way I describe EPCR is it's only the second most hated documentation technology after the EHRs that you use in the hospitals, right?
Right.
I have yet to meet
40,000 clicks a shift or whatever it is.
There it is, right?
Yeah.
And it was tragic. This came up during COVID-19 when I had the opportunity to work with a number of responder agencies, fire, EMS, public, private. Everybody got slammed, right? And some of these systems, both large and small, took it very, very seriously. And I was very proud to experience this firsthand, that they needed to protect their people.
Absolutely.
Right? They changed processes. They went. I mean, they ate that training. It was a bitter pill in a short amount of time, and by gosh, they did it, right? And when you look at the stats on the recovery in those services, their ability to be resilient, I think it bore out that it worked, right? We came through it. But that was really what got us looking. It was one, I won't mention which it is now, but one of the largest fire-based services in the country. And their vaccination records were yellow cards in a file cabinet. Thousands of people. I mean, these were a very, very large and complex service. And they found themselves in a normal situation that wasn't necessarily a problem for them. But now they needed to know not only who had what vaccine, but who had what allergy, who had what underlying contraindication, right? Who may have had a religious objection, right? I'm going to be talking about this a little bit in my discussion. One of my degrees is in religion, and it actually is the portion that I say truly I use the most in this profession. I think it's a very faithful type of person that runs, pours the crisis, right? Lifts the fallen in a very literal sense, and so being, recognizing that people have a strength, forgetting all the politics, they may actually have a religious objection to certain types of interventions. So certainly we're having this conversation finally with whole blood, which we're going to talk about a little bit in a minute about Indianapolis EMS and some of the discussions coming out of here that I'm fascinated by.
Absolutely.
So when you look at I almost lost track of my thought a little bit here. But I think when you talk about how we teach people in this profession about what it means to take care of their own health, recognizing that folks hate their EPCR systems by and large, except those who use, a certain company's system. Just saying. But really,
what is it? Let's hear it.
oh, MetaView from Beyond the Technologists. Thank you very much for that. We have
to draw that out of me.
I'm actually, in all seriousness, when I put my journalistic hat on, I do not talk about anything like that. I've been a journalist for a very long time, and we draw. That is a very strict break there. But really, there is. I do think there's an allergy to good data in this profession, and some of it is conscious. Some of I don't want people looking over my shoulder. Right? Some of it is a lack of understanding of the implications of data. Some of it is the mandates by which folks say you will push this button without explaining what the value is of that. But what I think we find when we start to talk about responder health, and this is a passion for me on the mental wellness side, is in those charts, whether it's on the EMS side, the fire side, or in the hospital too, right? In your EHR, right? There is not enough, I should say, because I'm involved in some of this, conscious effort to mine those data for psychological exposure, right? We do for blood exposure, for sputum, for fluids, for infection, but we don't look to say, are you having a really bad day?
Yeah.
Are you having a bad shift, a bad week, a bad month? And are you going to, without a release valve, are you going to do something that you can't come back from? Because folks aren't viewing these data as valuable in that way. But when you talk about the science, that is the primary data that we have. How do we, going back to this question, and I know I do this, Jeff's used to it, but
It's okay.
But we were talking about Pulse Point, we talk about Narcan, we talk about 911, 988. Are we taking care of ourselves in a way, or how should we, in your professional opinion, both state and local, right? How do we get the word out that there are tools and technologies, some of which you already have? You have an EPCR, you have data analytics. You may not know how to use them, but if you ask the question, there are people who would come in and say, you can find in those data all the things you need to keep someone from putting a bullet in their mouth. How do we teach this profession, just the same way as we do for how to climb a ladder, how to intubate, right? How do we teach them to take care of themselves?
Yeah, man, that's again another.
You only get 140 characters.
Yeah, I say, yeah, I could probably eat the whole rest of this podcast talking about that side of things. But
there's a reason I asked that question.
Mental health is always something that's been a passion of mine as well. And I think number one is it's interesting the dynamic between a local system and the state side of things as well. There's some local systems that do excellent behavioral health support for their services. And
what makes them excellent?
They have peer
you
support.
can name names, by the way. We'd love
They just it's just more intentionality of it. They have peer support mechanisms in place. They have I do tactical medicine. Our SWAT team has a chaplain on every call. I mean, he's out there.
That's cool.
A lot of the things that people look at and say, like if you make a run on a pediatric arrest, it's intuitive that people might struggle with that, but it's when it's not intuitive that I think is the challenge, right? That somebody reminded you of, when you had a traumatic experience with a parent or, some things like that. And, I think being intentional, these periodic check-ins, and then to having that, that conversation between the local and state level of saying, what do you think you're doing right at the local level? What are your holes in the system? And, how can we support you at the state level to plug some of those gaps you may have? Because it is very challenging to have all those aspects I mentioned earlier. Again, some resiliency training, some peer support, critical incident stress management, all those things. It's very challenging for a system to have all those things and have all those things be effective. So being able to have that conversation of what are we doing right, what are we doing wrong, and being intentional on help filling those gaps is probably step one. I mean, as a profession, the first responder profession is terrible about accessing care. If you put a phone number on the wall and say, yeah, if you're not feeling good, call this number. I mean, that thing's going to collect dust. But having some periodic check-ins and things like that, but finding that balance between that and just saying I want you to do your behavioral health module, that's not a good use of people's time and counterproductive. So finding some way to do some outreach where people are comfortable talking without it being intrusive and feeling like they're just a number and going through the motions, I think.
Well, I'll tell you, in my case, I have said, and feel free to take this back with you. I don't think it's enough to reduce stigma. I think we need to focus on eliminating it.
Yeah, of course.
And well, that unfortunately, what I find is much of it's better than nothing. But I think much of the discussion is on lessening it through open door and so on and so forth. But we wouldn't be satisfied. And I do truly look at it as follows. We would not be satisfied with reducing the incidence of smallpox, right? We needed to end smallpox, right? We don't talk about, reducing the risk of adverse encounter with a child with an underlying condition and autism, et cetera. We want to eliminate those adverse encounters, right?
Mm-hmm.
The idea that I just don't think we go far enough.
Mm-hmm.
So again, let me ask you this. Again, feel free to defer on this question, but is there anyone that you have seen, particularly in your coverage area, that you think is doing a really great job that should be emulated by folks and say, teach us more, invite us to speak on this topic?
One thing I think that happened in Indiana that I thought was really cool is, are you familiar with the Project Echoes at all? They're across the United States, and it's basically a way to kind of bridge the gap of some of the knowledge translation to our rural communities or anywhere through some virtual things. So you'll have a Project Echo on, we did one on MIH, and everybody can tune in. You have like what they call a core group, and then you have spoke teams and things out there, and you talk about different topics. Well, during COVID, we had one that was on infection control and just how to keep people safe when they were transporting COVID patients. But when our core team was sitting down and talking about it, we realized that out of like 6 of us, 4 of us had strong behavioral health backgrounds. And so what we would do is we'd have a case and we'd do our education modules, but then we'd open it up to discussion and kind of go into the behavioral health realm. And it was amazing how much people would open up. I mean, and attendance kept skyrocketing each time, and people were having very open, frank discussions.
For themselves or for their patients? Or
for themselves.
Okay.
For themselves. And it was really interesting because I'm not sure if we would have put it out there and said, we're going to talk behavioral health on this Echo, that we would have got the same thing. It was like they signed up, and then when you made them comfortable talking about some behavioral health issues, people were very transparent. But I'm not sure. I think it's a stigma thing. I think if you said, we're going to talk about your own mental health, I'm not sure you would have got the same level of engagement. So I think that just underscores the need to find creative, access points to get somebody to the table and then try to, get it to the discussion to go in an area where they feel comfortable opening up.
It's part of what fascinated me. Again, we dug in and I got serious, I guess, when we're talking about knowledge transfer, right? But that's what communications are. It's what journalism is, right? We want to spread the word. It's funny because it doesn't often get associated with science. But this is actually, I think, where journalism and science come together, and medicine in a very important way. We have to get the word out about what's going on out there. And it takes me back to that Nintendo example, right? How does everybody know to blow the
Throwback
card?
reference right here. That's like,
The what?
that's like an hour ago we talked about that.
Yeah. No. I'm going to keep going.
It circles back.
I do. For better and worse, I do. And it actually, and talking to you about this is so fascinating. I mean, you're touching on so many points. We're going to come back to ALS and CP in a minute too. So just gear up for that. But the question of is it enough and how did word spread and so on is a really fascinating question, I think, because again, when I look at this conversation around stigma and the need to eliminate stigma, it's, again, I'm going to take that into the CP realm in a second, because I think it's different, like the way that it impacts people. We're starting to finally talk about what that difference means practically. But I don't think I've gone to an event in the last, call it 3 years, right? Even attended an event during COVID, right? You weren't even there. You were just listening to people on Zoom talk about it.
Yeah.
And the stigma and the need to reduce or eliminate, attack, address, all those things, the open door policies, everybody was talking about it, which is good. So why is it still here?
Yeah.
So why do you think it's still here? I mean, again, now we're at the point where everyone's talking about blowing in the cartridges, right? You're almost at the point where if you're not blowing into the cartridges, something's weird about you. So how is it that there's still a perception or a persistence of stigma when at this point, so much leadership effort and bottom up effort, right, is meeting in the middle, talking about stigma is bad, dialogue is good. What's missing? What's the What takes it over the tipping point?
I think it's interesting. I think I agree with you. The awareness, now versus 5-10 years ago, it's astronomically different. At the end of the day, that doesn't always still put butts in the seats, and I think some people are still hesitant. They understand the awareness. They're starting to understand the pathways, but it's still another step to actually sit down. And I think you're seeing more and more of that, but I think it's something that's not going to happen overnight. And so I think, again,
is 5 years enough?
No, I think we need to keep, it just needs to be such a pervasive theme, and again, to drop as many barriers as possible to make it, easy to access and almost understood that almost everybody should have those interactions, at baseline, to have those discussions instead of, nudging someone to make a phone call. It's, there should be periodic check-ins and, and developing those relationships so that when something does come up, maybe I'm doing fine. But, if I have somebody that periodically checks in with me, I develop that trust, that relationship, the one day when I'm not, I'm already have that in place instead of, a cold call or somebody that I don't have that pre-existing relationship with.
So maybe it strikes me as a phenomenon of the types of things that people in this profession need to learn how to deal with physically, mentally, emotionally, otherwise. Again, we're at an event where there's a lot of focus here on physical safety, right? Get used to, drill on your gear, right? Know your processes and so on. But to what degree, I guess, this is a hard question actually for me to ask, because we all experienced this close to us. Why do we need tragedy to get us to do things?
Wow.
Man, that's
deep.
Yeah.
Well, I'm gonna keep going. There's more to it, but I think this is. Go ahead.
No, I think we're that way in so many things. I mean, even COVID, what did COVID select for? Some of the, it showed, some of the warts in our healthcare system, that a lot of EMS systems were hanging on by a thread from a workforce side of things. And sometimes it takes, unfortunately, and tragically, it takes a tragedy to, bring that realization up and to give that nudge to enact some true change. And I think that's the key, is anytime something like that comes, any kind of sentinel event, whether it be behavioral health, medical error, what that looks like, you have to sit down and have a frank discussion of why did that happen? What were the steps to lead up to it? And what can we do different to make sure that never happens again? And it's a shame. You're exactly right. I always say that in the ER sometimes when I'm frustrated about something. I'm like, why do I have to act a fool to get this done? Why can't I just say, let's do this? But that sometimes it's just human nature. And so I think it's important that, things like this are going to happen, but you've got to sit down and debrief afterwards and figure out how it'll never happen again.
Well, the challenge that I see when it comes to that, and again, I don't think this is limited to mobile medicine or EMS, fire, et cetera. I think we're having the struggle as a country right now. Where, pick a school shooting, right? It's not even the school shooting anymore. It's a school shooting, right? And that's disgusting on every level. But it was a friend of mine who runs an ambulance service in upstate New York. Not long ago enough said what he thinks is going to change the dynamic around the economics of mobile medicine is a death in the back of an ambulance, and he just hopes to God that it's not one of his. And he was looking at this idea that you have folks in Congresses and in state houses and so on and so forth who don't seem to understand the gravity. And I'm not just talking about economics. I think economics is a part of it, but also the burnout. So I mentioned I was going to sort of tie this back to CP and some of the psychology there, and ALS. So we had a loss very close to us. He was actually a member of our team. His name was Bruce Graham. He died of ALS a couple years ago. He was in Ohio, so not all that far. And at the time, community paramedicine was not allowed in Ohio. Bruce was a huge advocate for community paramedicine. He was a EMS agency chief. He had been an agency chief. So he understood. He was I think it was the vice president of the Ohio EMS Chiefs Association at one point. And this was the worst, sorest, meanest irony is that this fellow who had advocated could have been a beneficiary of that in-home care and couldn't get it. Right? And so you combine this thread of the remarkable and tragic prevalence of ALS and of other neurodegenerative, et cetera, conditions in our industry, in our profession, to quote Mike Touchstone.
Mhm.
And then on the other hand, you have this question of access and whether that access is as bad for the folks who are in this, right? It's a joke that I learned 15 years ago that the worst firefighters and medics are the worst patients.
Absolutely.
Right.
Yes. Yep.
And so when I think about, let's thread these together again, this is why I may seem like I go in these crazy curly cues of conversation, and I do.
Spit take right here.
What?
Spit take almost.
Yeah, I do. But think about how all of these come together, right? And they come to a sharp point. Right, you've got mental wellness, you've got physical wellness. I wrote an article a couple years ago called "Coping is Different, but the Heroism's the Same," and these were from folks that I learned from around the mental anguish. Is the only word I've come up with to describe watching a community paramedicine patient decline, because for most of us, life is a terminal condition, right? But the difference being when you're dealing with whole blood in trauma, you can compartmentalize that differently than when Mrs. Smith and her dreams and her wishes and her kids and heaven help you, you've watched a child decline, right? And again, I just came from this conference where kudos to you, your team for the Title V agency here loves you. And I guess I told them that I would present. So it was Eden and Kate, right?
Absolutely.
And I mean, they just had nothing but amazing things to say about you. That's not typical. In fact, I think I probably represent more people in this profession by having not known what a Title V agency was. So Title V is the Title V of the Social Security Act, essentially funding allocated toward maternal and child health. That's sort of a high-level overview of this remarkable program and set of programs and monies associated with it. Talk to me a little bit in a few minutes about how you have engaged in both your crews, your teams across the state, but locally, about how do you prepare to watch somebody decline? And then at the same time, when you see the innovations that teams like the Title V agency are doing, how are you working to spread the knowledge, spread the love about those innovations to communities that need to know about them, but don't?
Absolutely. Number one, our State Department of Health is an outstanding partner to EMS. They really are. And it was one of those like stepbrothers where they're like, did we just become best friends? Because they were talking about their goals and we were talking about some of our goals from an EMS side of things, and especially the CPMIH realm. And I mean, they just meshed perfectly. Again, in my home county, we had we had 2 of the top 5 zip codes in the state for infant mortality and safe sleep deaths. And again, some of the local fire chiefs, if you talk about, who's first on the scene, again, you go back to mental health and traumatic events, and you talk to somebody who's in the fire service down in my area, and any run they've made, they can tell you, where it was, what day it was, things like that. Those are traumatic. In there, right? Yeah, those are traumatic things. And same thing. I mean, every newborn fatality I've ever worked in the ER, I mean, I can still picture the family's cries and things like that. So it's like we've got to do something, and they gave us the tools to do that. And then we, from our MIH side of things, I always say that MIH can be the delivery arm for all these public health initiatives. And it's versatile, right? You tell me tomorrow that we need to do something from a MIH side of things different to meet a community need, we can do that. Whereas if you wait till it's brick and mortar and things, that can take years of expense and things like that. And you go back to the postpartum depression. I don't know, I have kids, and I'm in the medical profession, and I remember, that 48 hours after delivery, it's information overload, right? You're just overwhelmed with people telling you all these things. And so we used to go into the hospitals and do some safe sleep education, on site. Well, now what we do is our MIH team goes out there 2-3 weeks after delivery. Once they're settled in, things slow down a little bit. Hey, are you doing okay? What do you need?
Awesome.
Can you have a crib? Are you personally doing okay? Can I link you up with somebody to talk to? Things like that, that once they're home and you can have a more intentional discussion versus just boom, boom, boom. Okay, now somebody else is going to come in and teach you about something else. And, those kind of things. And, they've been super supportive, and, that's a passion for all of us. So it's just a perfect partnership.
Well, and again, Jeff knows this about me. What I try to do whenever possible, and this is why I was actually thrilled that he connected us to talk on this. And I just think serendipity, again, almost the religious nature of being in the right place at the right time with the right person. It is 48 hours ago I was having these conversations.
Yeah, it's crazy. And you're out in California.
I was out in California. Well, and not to put too fine a point on it, but the week before that, I was at an event that I was one of far too few people from this world. That was the Lifesavers Road Safety Conference, which is directly tied in with things like NHTSA and NEMSIS and et cetera. And the week before that at the Coalition for Compassionate Care of California, which is all about palliative care. And I was not subtle because I'm really shy and quiet. I don't talk.
That's sarcasm.
Was that spitting? But I was not subtle about the fact that EMS, fire, et cetera, were not in the room for these conversations. And I actually got thanked. It was amazing. Several people came over and said, "Thank you for." We didn't know how to spell EMS, and the idea that when something in hospice goes sideways or hospital at home, right, sort of tucked in under MIH, all these new models of doing things, or not even that new. It's kind of the return of the house call, right?
Yeah.
But
Yeah,
that's really what it is.
Absolutely.
What I find, it's a distinction without a difference. And the idea that all of these allied professions are called that, they lay on a continuum. They work together in reality, right? I say it in sort of shorthand when I do say things shortly, which does happen rarely. Right, sorry, other mic drop moment. That when the tones go off, everybody shows up. Beyond that, it's all union stuff and political BS and whatever. And there, those organizations have their role. I don't want to throw them under the bus, but they end up not being. It's not reflective of the reality of what happens when you go out. And so I find it to be both terrible and extremely optimistic at the same time. Actually, for me, it's also an ode to Mike Touchstone. Mike Touchstone, I'm sort of stepping into his shoes. He was a mole. He would go from event to event to event, right? And take little bits of it back everywhere and sort of say, did you know they're doing this over there and over here and over there? I'm trying to do the same thing. And when I hear about examples like what you and your colleagues are doing in Indiana, it's almost a perfect confluence, right? My passion in this podcast, in our last couple minutes here, is to tell the story of innovations that don't get attention, right? Media, everyone in media knows that the places that get the attention are the places where the media companies are organized, right? I mean, everything in New York, Los Angeles, San Francisco, Boston, DC, Chicago get much more attention than any place else. But we talked about Midwest earlier. I wrote an article for GEMS with a fellow named Tom Jenkins. I don't know if you've heard that name. He's involved in the nearest transition, the fire record system. And he's an amazing innovator on the fire side. And it was called Innovation in the Heartland. And it was about all of this work that's being done in rural environments and, having been to a lot of these places, I don't call them flyover country, but people from my state sure do, right?
Oh, sure.
And the idea that there is people from your state do too.
Oh, yeah.
Right? So the idea that there are amazing innovations. I've had a chance to work with some public health districts in Kentucky. When people talk to me about sustainable community paramedicine, the Purchase Area Health District in Paducah comes to mind. Right? Years of CP programs that they did, building on their success, right? It wasn't, we're going to replicate what everyone else does. We're going to understand our needs. And so I want to take to sort of end on a high and innovative point, something that's come up to me in a remarkable fashion when we talk about things like whole blood. In Indianapolis, folks from IEMS, can I mention Shane on the air?
I think you can.
I can probably mention Shane on the air. Right? So I sat down with Shane Hardwick.
Absolutely. Yeah.
And
everyone does. I think everyone does.
Yep.
We got you, man. Didn't know you were making a cameo. Could have been in the room. So I'll meet you at St. Elmo's.
There you go.
So we sat down at the National Association of Mobile Integrated Health Providers conference, and the first thing that came out of his mouth was, I want to talk to you about drones and whole blood.
Awesome.
This podcast, let's wrap it up, John. We got a time ticking. 30, 29.
I'm going to go a little over it. But it was really wonderful because at the same time, just before he mentioned that, there had been a federal solicitation around drones and blood delivery. Mm-hmm. And I asked him, and this is why I think this is so wonderful to end on. And I want you to tell me your thoughts on some of what these types of programs.
Quickly. I was a producer in past life, so commercial break.
Give me commercial breaks. I asked him if he had heard about this federal program, and he had not. Mm-hmm. This was so I thought maybe it was a matter of like, let's go after these dollars. Yeah. But instead it was, we've had this conversation. We want to do it. Let's go find the dollars. It wasn't chasing the money. It was, what do we need? And his specific discussion was around the rural and the urban and the traffic on the freeways and trucks all over the crossroads of America. So when you look at the communities that you touch and the programs that need to be highlighted, right? That's one that comes to my mind.
Absolutely.
But are there others, again, what would, if you were to think of the top 3 programs that are in your Vista that you think don't get the attention they deserve, but you could call them out right now, what would come to mind?
Probably number 1 I would throw out there is Crawfordsville, Indiana. Small town Indiana. I have some family there. Nice small town, nothing special, unique, different about it versus other towns besides leadership and passion. They have one of the strongest MIH programs in the country. They do some amazing things.
They punch above the weight too.
Oh my gosh, yes. Yeah. I mean, they really do. But it's because of leadership from the mayor down. And my 2 biggest passions on a personal level are MIH and then whole blood in the field. So again, it's one of those. Did we just become best friends? Their chief was in the same frame of mind, and we work together on MIH. They do Project Swaddle, where they have all sorts of OB support because they're in an OB desert. And then a few years later, he came and said, "Hey, I want to do whole blood." And I think he's in that sweet spot of, I call it the transition zone, where you're far enough away from a trauma center that you have some longer transport times, but you're not necessarily so far that you just have to fly a major trauma. And I think that's where whole blood can make a big impact. And so he's actually, as of starting in 2024, he's a rural EMS service, and they have whole blood for their citizens.
That's great.
And it took a lot of work and passion to make that happen of a lot of people. So.
2 more.
One more.
Okay.
One more.
1 more? 1.5 more?
One more. We gotta wrap up.
I think
this is good stuff. It's amazing stuff. There's so much to talk about, and we got to bring them on again for next podcast, webcast, right for us. So.
Yeah, gosh, I don't know. I'm gonna get a lot of grief as soon as it's over because I'm gonna get like 18 texts. Well, what about us? Why didn't you talk about us?
Bad.
Let's do a follow up. What if we do a follow up of sort of your top?
I can do that. Yeah, I'll be down with that. I'll be down with that. So yeah.
So Dr. Izzel,
give me 1 more.
Jonathan, we got wrap.
1 more?
We gotta go.
No more?
No more.
Jonathan,
I'm getting the vaudeville cage.
Yeah, the cage.
Fair enough.
You the rules.
This has been a pleasure.
Absolutely.
It's
Thanks
great
for having me.
Jonathan, Doctor, appreciate it.
By the way, you like how we circled all the way back to the beginning?
Yeah, it was great.
That curly cue, it drops you off
like
right by the gift shop.
I'm glad we got Hardwick in there a little bit. So, yeah.
He's great.
Thank you, everybody. Are we still on? Thank you, everybody, for joining us for this.
No, he doesn't.
I don't even know.
We got him on there, man.
Thank you for attending this live special episode of Sacred Cows and Data Cubes at FDIC. Appreciate you. Stay safe out there.